Hi, this is Dr. Pat Corrales again with a follow-up podcast on our original podcast on menopause, which is Hot Gals, and we're talking about hormone replacement therapy, what you need to know about it, since that is the most common therapy that is utilized for patients who have symptoms of menopause. We had talked about the fact that menopause was a time where women's hormones that were elevated during their reproductive years actually begin to decline. And what you see here is an actual graph of what happens to estrogen and progesterone from their reproductive levels during the postmenopause to almost negligible levels. You can also see what happens to men's testosterone, even though it doesn't decline as precipitously as estrogen does. It has a slope which is declining as well. Testosterone, which women do produce, actually declines slightly, not as much as the estrogen. So when we talk about testosterone replacement, we have to be aware of the fact that it hasn't actually declined very much. So estrogen therapy and hormone therapy in the 1960s was thought to be the fountain of youth. And then in the 1970s, it was linked to endometrial or uterine cancer, and it became a poison. But we learned that if it couples with progesterone, not just estrogen alone, it actually reduces the risk of endometrial cancer because progesterone has the greatest effect on the lining of the uterus. So that's why giving it back essentially protects. In the 1980s, we found that taking hormones prevents osteoporosis, and we realized it could be used to protect against bone loss and bone fractures. In the 1990s, that thought that it can be protective was expanded, and that's when the Women's Health Initiative was funded by Congress to try to see if taking hormones would actually protect the heart and other organs as well. But unfortunately, in the interpretation of the study, which was ended before its entire length was allowed, it was back to considering it a poison. Why? Because there were higher rates of breast cancer in the study. The problem is when they looked at the data, they were interpreting the data only in the overall setting. They did not take women who were at the beginning of their menopause. They took them at all time periods. They could have been in menopause for 20 years, or they could have been in menopause for only a month. Additionally, they took women at age 50 and they took women at age 70. So there's a real problem in terms of how the study was actually designed to come to the conclusion that estrogens and progesterone and hormones are a poison. So when they looked back at it, they realized in 2016 the indications for hormone therapy are specific and they have to be individualized. Each woman is their own person, and therefore it's not one size fit all. And we are back in the time period when hormones are part of the therapy used for menopause, and the risks are not as high as they were previously determined. Also, since 2016, in looking at the WHI data, they realized that breast cancer risk for the estrogen arm of the study was really not evident and didn't occur until 15 or 20 years of using it, and it was very minimal. Also, the risk was higher for women who had basically been using it for more than 5 years. And the risk, though, was not as high as was previously touted. And it was only as high as if you took 2 alcohol drinks a day, which a lot of women do. Women's Health Initiative, looking at breast cancer risk alone, did not see estrogen risk, okay, after 15 to 20 years. So it made a huge difference if you were on estrogen alone versus estrogen and progesterone. So what does all this mean? It means it was ripe for more studies. Okay, and there was a study in 1998 which used multiple ethnicities and multiple centers, and it was simply following 3,300 women who were on estrogen, who were not on estrogen, and basically lost that estrogen effect at menopause. And they realized that women's vascular bed, their heart arteries, their brain arteries became stiffer. So that was the impetus to study giving back estrogen as a way of reducing heart and stroke risks. And the Chronos study that was done in 2019 gave oral estrogen and transdermal, which is a patch of estrogen, to 800 healthy women and followed them to see if it actually slowed the progression of cardiovascular disease, and it was safe. And they found that it was safe if they gave it to them in early menopause. In a study that looked at early versus late interventions, the same thing. If it was initiated early, within 6 years of menopause, versus later after 10 years, it actually slowed the progression of cardiovascular disease. So the reinterpretation of the Women's Health Initiative and these other studies all suggested that estrogen therapy and hormone therapy was not a poison, that if it was used in the right way, it actually would be helpful to women. Not only helpful to treat their symptoms, but helpful also to prevent rates of heart disease. And so the current guidelines, which placed a warning on all forms of estrogen, the creams, the tablets, the strings, which weren't even systemically absorbed, these were just local estrogen treatments, was removed. And it was re-evaluation of the data that and the newer research that suggested that hormone replacement was not a poison, that it was actually beneficial for symptoms, and in many, many women did not increase rates of breast cancer and cardiac events. It actually protected against them. In the breast cancer controversy, it has been important to realize that there is no negative effect on breast cancer. In women who have active breast cancer, it is an individual decision with their doctor as far as their particular risks. And traditionally, what we do is we do a risk assessment for breast cancer and a risk assessment for cardiac disease before we begin women on therapy so that we can sit with them and have a discussion. The key points are timing. Treatment with hormones should begin before the age of 60, within 10 years of their final period when they are truly in menopause. The type of hormone replacement is also important. In the WHI study, they used conjugated equine estrogen, which is obtained from the urine of horses, mares. And now we have synthetic forms of estrogen, and we have low dose formulations. And so they have a very low effect. We also have found out that the patches or the transdermal, the creams that are put on the skin, are the lowest for risk because they're not passed through the liver. And so they don't have high rates of leg clots or stroke. In fact, they reduce the rates of stroke. So how long you should treat is somewhat of a question mark at this point, but the studies have suggested that you should not treat more than 5 to 7 years to lower the chances of getting breast cancer. But that's an individual decision as well. So what's the take-home message? You want to use the lowest effective dose. And so what do we have now? We have estradiol, and we begin it at a extremely low dose, almost half the dose of the old conjugated equine estrogen that was used in the WHI study. And we have newer forms of progesterone because every time you have a patient with a uterus, you have to give both estrogen and progesterone to protect the uterus from any cancer development. The newer forms of progesterone include micronized progesterone, norethindrone, and drospirenone, and they too are at half the dose of the old medroxyprogesterone. As far as how these are delivered, they can be given continuous or cycled. The continuous regimen is associated with fewer vasomotor symptoms, hot flashes, and it leads to no periods. And for some people, a little better symptom control. Most women don't want to have a period anymore, and so they prefer the continuous regimen. As I said before, the transdermal hormone patch, both estrogen and progesterone, have the lowest rates of side effects and are very useful in managing hot flashes. They also have lower rates of clots and stroke. Hormone medications include transdermal, as we said, and there's a combi patch that's available. And there's also something called a fem ring, which can be placed. You don't have to think about taking it. You don't even have to think about changing the patch, and it stays there and is changed every 3 months by your OBGYN. One comment to make before we go, and that's there are compounded bioidentical hormones out there, and that's been very popular with some women thinking they're going to avoid the side effects of the actual estrogen or progesterone, and these are heavily marketed, and they're, however, not well studied because they are considered nutritional supplements. They're compounded by a pharmacy, meaning they make them, okay? And it's so therefore they don't require any FDA approval. And so they're not well studied, and they are not required to show any claims that they're effective because they're just considered nutritional supplements. And it's important, I think, for you to realize these are not recommended by the two major associations that are asked to evaluate the effectiveness of treatments. With that, remember, it's a discussion with your provider as to what's the best for you to understand the benefits and the risks. All hormones have a positive effect on symptoms. If you just have the genital urinary, the local hormones have no systemic absorption and therefore are safe for women with heart disease and breast cancers, and if taken correctly. And the systemic hormones also have very low risk, but each woman is an individual, and that's a discussion with your provider. Thank you.